Okay, this PowerPoint is actually sort of a mix of pieces. I kind of reworked it. This year I made this one new just because I didn't like it was getting kind of, I don't know. I didn't understand the flow, and I still don't know if I understand the flow, but a lot of this material comes from chapter 8 and then other resources. So I tried to streamline it a little bit, but I also had to add a couple things because the topic is antivirals, and so I wanted to put in some other viruses that we might commonly see in practice. So these are there's 2 slide objectives. This is the first slide objective, to describe the function and components of the blood. So we're going to talk about just the blood because, you know, viruses oftentimes are spread that way. Explain pathophysiology of HIV and AIDS, recognize possible oral manifestations of HIV/AIDS, discuss treatment rationale, explain the pathophysiology of tuberculosis. We'll talk a little bit about tuberculosis as well, which feels odd because it's not a virus, it's bacterium. So I'm not sure why it's next year. I may be moving this. I think I thought I needed to, but I didn't. And then herpes simplex and chronic hepatitis, very 1 slide, maybe 2, I can't remember, of herpes, of hepatitis, I mean. So just a little bit there, and not a ton of medications. But we want to talk about the components of the blood, as this is probably a review. You guys, I'm sure, have talked about this in other classes and prerequisite classes. So the blood is composed of parts, a liquid part, which is plasma, and the plasma is what carries a lot of the components of the blood because it's a liquid. So might carry waste through the body, vitamins, but it also carries the red blood cells and the white blood cells. So it's sort of the liquidy portion. That makes up a little more than 50% of your blood volume. And then you have the platelets, which really aren't a cell, but almost sort of like a piece of a cell. And they're specifically designed to help in clotting, right? We can think of platelets for that reason. And we also talk about it when it's doing what it shouldn't be doing, is overclotting. But so platelets produce tiny fibrin threads, and they sort of patch up, and then other parts of the blood sticks to it to help form a clot. And then we have the red blood cells, which are the second largest portion of the blood. The red blood cells, 42%. And of course, a red blood cell carries oxygen and carbon dioxide. It doesn't have a nucleus. So it has the ability, it obviously can't like regenerate itself on its own, but it has also the ability to kind of morph a little bit and squeeze through the different twists and turns and sizes of arteries and capillaries. It's kind of designed that way with this kind of donut shape. And then because it doesn't have a nucleus, it sort of has a lifespan. And the lifespan of red blood cells is about 120 days. And then we have the white blood cells, which make up a very small amount, but potent, powerful little suckers. That's our immune defense. And they also do the work of phagocytosis, eating up the junk that we don't want in our bodies. So just being familiar with this on a very kind of broad term, there are questions about this on, I can't remember if it's the exam or a quiz, but I do remember seeing questions. So you do need to be familiar with these slides. What's in our blood? So white blood cells produce and red blood cells, both are produced in our bone marrow. We have in the white blood cells, granulocytes, lymphocytes, monocytes, macrophages. They're all different components of white blood cells in our immune system. The granulocytes, that's the largest component, up to 90%, and the neutrophils are parts, but those are specific granulocytes. Those are a form of a granulocyte, and those defend against bacteria. Then you have the eosinophils and the basophils, which make up about 10%. And those react, they start inflammatory reactions or allergic reactions. So those can be maybe the ones that tend to overreact perhaps when we have something going on. Then we have our lymphocytes, which are the B lymphocytes and the T lymphocytes, or B cells and T cells that are sort of for short. And we'll talk more about the T cells when we talk about HIV and AIDS. They produce specific immune response. They produce antibodies. And then we have the monocytes and macrophages, and they have all kinds of different functions. And we're not going into great detail about all this. This has lots and lots and lots of information that you've probably had to learn at one point. Maybe microbiology, is that where they talk about this? I can't remember, it's been so long. But we're not going to go into deep dives. So a little bit about a healthy range for your white blood cells, because if you get out of that healthy range, there are problems there. And so just understanding that, since we're talking about the blood. So a range of white blood cells for a normal healthy person is between 4,400 and 11,000 cubic, what does my note say? Cubic millimeters. I always forget what those little things mean, so I have to write it down. Cubic millimeters. But you don't have to memorize that for a quiz. And then leukocytosis is high levels of white blood cells, greater than 11,000. Possible causes of that can occur during pregnancy, maybe intense exercising, emotional stress, infection in the body. So there's things that could make you bump up above normal, and then perhaps it would just be temporary. And then leukopenia, lower levels of leukocytes, less than 4,400. And of course, one of the most concerning reasons for that would be early leukemia. It could also be a toxic effect of drugs. Drugs can lower the white blood count, especially like a chemotherapy or something for treating a cancer. Okay, so that's all we're going to talk about specifically with the blood, and then we're going to move on to the herpes simplex. So there's simplex 1 and simplex 2, not really getting into differentiating. It's sort of more of a general knowledge, because you will see quite a few patients with cold sores, and the biggest thing you want to realize is that you don't want to treat them. They have an active lesion, and you've probably already heard that, probably from another class already. But herpes are associated with cold sores. And as a dental practitioner, your patient may come in and be like, oh, I have this really painful thing. Do you have anything to help? There are things that, so I've worked in offices where they've had different medications. Some of you may have as well. And some offices that do laser treatments can treat cold sore with a laser. If it's in a certain phase, it works better. I think if it's all crusted over, I don't think it works as well. But so there are things that perhaps your office might be able to do to help a patient who has an active cold sore or herpetic lesion. Most antiviral agents are either purine or pyrimidine analogs that inhibit the DNA, the deoxyribonucleic acid synthesis, the DNA synthesis of the virus. So they work on the DNA. Bless you. And we'll talk about the medications in just a minute. This herpes has neurovirulence, meaning that it has the capacity to replicate in the nervous system. So it hangs out in your nervous system, and it travels along your nerves to express itself. And herpes specifically lays dormant in the neurons of the trigeminal ganglion. So some people can carry, actually a very huge percentage of people can carry the herpes simplex virus, but never express it, or they may only express it like one time and then they never express it again. And then other people will have like regular cold sores, like once a month or something like that. And it just has a lot to do, I think they don't know fully, but sometimes they think, food can trigger it, sunshine can trigger it, stress, illness. Some people's immune system might just clear a virus. It's kind of like HPV. Some people's bodies will clear that virus, whereas other people's bodies won't. So it's just our unique, whatever's happening in our bodies. But a third of all individuals will have the virus for their lifetime. The primary infection can cause acute gingivostomatitis. So if they have that, like, and they might have their first outbreak when they're a child, and they could just be like, oh my gosh, like swollen gums, swollen mouth, swollen lips, super painful. And then the ones after that might just be like a cold sore or something like that. They can feel fever, malaise, nausea, vascular lesions, gingivitis. And this is what's really important to note is viral shedding can continue in the saliva for 3 weeks longer after the visible sore is gone. So it's like, that's kind of crazy to think that there's virus in the saliva in like 3 weeks after. And so going in there and ultrasonicking, and we know anyways that down in periodontal pockets, there's all kinds of fungus and bacteria and viruses down in the periodontal pockets. Who knows what's down there, but it's just kind of a crazy thought. So if somebody has a cold sore that is just healing and it's like looking like pretty darn good and it's tiny and you're like, probably okay, but it's just not. Like, just say, well, we're going to reschedule you for when that's all cleared up, because you could reinvigorate it and spread it all over the place, and you don't want to do that. Subsequent outbreaks vary with individuals, not as severe as the initial occurrence. And then I just got a few numbers off of NIH. Worldwide, 90% of people have one or both viruses, HV1, HV2. HV1 is more prevalent, 65% of people in the US. And then John Hopkins says 50, oh, sorry. Hold on a sec. Okay. John Hopkins says 50 to 80% of American adults have HSV. I keep saying the wrong thing, but HSV1, which causes cold sores or fever blisters. So that's a lot of people. That is a lot of people. All right, so the medications, there's not a ton of them. Zovirax or acyclovir, it inhibits DNA replication, it lessens the effects, preferentially taken up by the infected cells. The side effects could be headaches, CNS effects. All of this medication is the most effective once they feel the kind of prodromal, or like the tingling before the vesicles kind of pop, or specifically before they like break open, they would start medication. The docosanol or docosanol, Abreva, that's over the counter, that's the cream. You can also buy a generic that just says docosanol instead of buying Abreva. And then there's valacyclovir or Valtrex, and that's mostly indicated for genital herpes, but I think they sometimes prescribe them both or together, depending on what the person needs. It could be prescribed at an outbreak, or it could be prophylaxis. If somebody has just recurrent, like they just always have recurrent outbreaks, they might give it to them as a regimen. Elective dental and dental hygiene treatments should be deferred for patients who present with active herpetic lesions. Treatments may be uncomfortable and the patient is at risk for spread of the infection or reinfection. And then oral health professionals are at risk of infection through aerosolization of the virus during dental procedures. So just protect yourself, keep your patient comfortable, and just reschedule them. Tuberculosis. Am I going too fast? Okay. Tuberculosis. So tuberculosis is not a virus, it's a bacterium. So it's a bacterial infection caused by Mycobacterium tuberculosis. The name indicates its formation of firm nodules or tubercles throughout the body. So we always think of tuberculosis sort of like a lung thing, but it can affect any organ of the body or other organs of the body. But a lot of times we think about it because of a cough or a productive cough. Microorganisms is inhaled through aerosol droplets, and the number of organisms inhaled in the immune system determines whether the disease is contracted. And I have this on a number of slides, but fortunately it's not super easy to get it. It's not like super contagious. You have to be around somebody, sort of like isolated in close contact with them for, a good period of time to actually contract tuberculosis. Individuals may be exposed but show no clinical signs. Pathophysiology of tuberculosis, it can infect any organ of the body, but most commonly affects the lungs. Droplets are carried into the alveoli. Host defenses control and contain the infection, resulting in latent TB. So latent TB or inactive TB, sometimes people just don't have any signs and symptoms. Their body's sort of keeping it under wraps. It's not contained, if not contained, granulomas form and eventually cause necrosis. So long-term, and that's why people died from it without treatment. It was kind of maybe a longer disease, but it was definitely deadly. Good news, as a rule, close, frequent, or prolonged contraction is needed to spread the disease. Some signs and symptoms of tuberculosis, 4 to 6 weeks after contact. So it takes a while for the body to show signs. Fevers, chills, GI upset, night sweats, and then later symptoms once the individual is into more of an active form. There's weight loss, nausea, vomiting, headaches, palpitations, and of course, kind of the thing we all think of like a bloody sputum cough, productive cough. So I won't play the video, but I tried to look for a different one too, because that one, do you guys know who this is? Yeah, Val Kilmer. From, yeah, I was gonna say from Doc Hollywood, but that's not the movie, from Tombstone. That's a good movie. But this is a video that kind of shows, it's a compilation of his scenes in the movie, because throughout the whole movie he had tuberculosis, because the real Doc Hollywood was like a real person and he died of tuberculosis, and he was a dentist. Who knew that? Do you guys know that? He was a dentist and he contracted it from his mom. He was caring for his mom, and he got it, and he ended up dying from it in real life. So he's playing like a real character. I'm sure there's Hollywood thrown in all over the place, but for the most part, that's, that backstory is true. And so if it's kind of fun to watch this clip, because he's like acting out some of the signs and symptoms. So that's why that video clip is in there. And let's see. So pharmacological management. So tuberculosis is hard to treat because it takes such a long time to treat. And so a lot of times there's not good compliance. And that's basically like the big take home point. People using anti-tuberculosis agents often don't take them as prescribed. They start to feel better. Sometimes the medication makes them feel sick, and they have to take it for so long. And then they're like, I feel better when I don't take this. And so it's hard to reconcile it, but it actually takes that long of a stent of the antibiotic to clear it out of their bodies. So then they get the drug resistance. So development of multi-drug resistant tuberculosis has continued to increase because of its spread among patients with HIV, immunocompromised, among the homeless, or if it's more prevalent in other countries. So it is still around, but a lot of times it's more immunocompromised individuals who will contract it. And so they're more vulnerable to it, but it's just a hard thing to treat because you have to take the medication for so long. Vaccine, unpredictable efficacy. I don't know that there's any vaccines for it at all. Maybe they're in the laboratory, they're working on it. I don't know. No elective dental treatment if someone has active TB. So you certainly don't want to treat somebody who has active TB. Duration of therapy based on drug regimen must be long enough to eradicate the disease. So these are the medications. There's 4 medications pretty much, and people can take a mix of them, but you just really have to memorize the isoniazid and the rifampin. This one would be given for maybe inactive, early stages, and then also for active. And someone might take both of them or these other ones too, if they're an active TB. And the therapy can last for months, like 6 months to a year. I mean, it just depends on, I don't know what they test. They continue to test the patient, see if it's cleared. take chest x-rays. I'm not sure exactly how that works, but it's a long regimen. For the isoniazid, it's highly specific for the Mycobacterium tuberculosis. Side effects can be vitamin B6 depletion and hepatotoxicity. And then for rifampin, activities against Mycobacteria tuberculosis, several other Mycobacteria species, and non-tuberculosis Mycobacteria. So it has a broader spectrum. And then GI side effects are most common, can turn saliva red or orange. That's interesting. Okay, so now we will move on to AIDS. Yes? I probably would not ask you. I mean, if I were you, I would highlight that, because like if I were to design a question, I would likely ask you about a medication that turns the saliva red orange over one that causes hepatotoxicity, because that's harder to remember. It's not so applicable, but something that turns your saliva a different color is pretty applicable to us. So I would be more likely to write a question on that. Yeah. Okay. Acquired immunodeficiency syndrome, HIV-Human immunodeficiency. So AIDS is a chronic disease produced by infection of the retrohuman immunodeficiency virus, or HIV. Opportunistic infections often occur in patients with AIDS, so they may be taking various anti-infective agents to prevent disease, such as tuberculosis and all these other ones. So the overall take-home point about a patient who has HIV/AIDS is that they could walk in and be really perfectly healthy. I mean, besides the fact that they're carrying a virus that's adequately suppressed, they could have no signs of anything. Now, if they are, perhaps they're older, perhaps they've lived with it longer, and perhaps they do have they've taken medications for a lot longer, their bodies had to deal with it, and the side effects of the medications, they may be, in general, maybe like weaker systemically. They may just be on a ton of medications that you have to make sure you know the side effects and the oral effects, or they could be more prone to infections, candidias, opportunistic pneumonias, things like that. So it's not to say that a person who has AIDS or HIV will automatically just present as a sick person. And I think you guys know this already, and you've heard this before, but these are just things to be aware of. So HIV/AIDS, the first case reported in the US in 1981, but they do believe that it was around at least a decade prior. They just didn't identify it truly, and didn't. So there's all kinds of, I mean, you could do such a deep dive into the history of HIV. It's really quite interesting, and you'd learn surprising, interesting things that haven't always been disclosed. But for our purposes, it was first discovered around in the 80s. The end stage of infection with human immunodeficiency virus, HIV-1 and HIV-2, is acquired immunodeficiency syndrome. So it's just basically saying that your whole immune system is severely depressed, and so it's manifesting itself in multiple different ways, with different systemic expressions. And a lot of times it's just opportunistic infections that take hold. Virus attacks the body's immune system, resulting in life-threatening infections and cancers that derive from it. Because your immune system fights off all of that stuff. Sometimes we don't always think specifically about how our immune system can fight off cancers, but it does. So very detailed. The good thing about having to kind of become familiar with this is that you'll utilize it we review this exact same slide next semester in special needs, and we talk about it in a lot of the same ways. So the nice thing is that you have repetition. I go into a little bit more detail with the oral manifestations. I don't do that so much in this one because you don't need an absolute repetition. But I really like this slide for a number of reasons, because right now we're focused on medications and the different types of medications that are used to treat somebody who has HIV. And so this not only kind of shows how the virus works and like what the virus actually does, but then these stop signs, each one of these has a stop sign. Have you guys seen this slide before? No? Each one of these stop signs talks about a medication that is like a blocker for that. So it would stop the flow of the rest of the activity of the virus after that. And sometimes they have to use multiple of these drugs. So I have a lot of good notes in the side that kind of describe this a little bit better. I think I might have highlighted it by the, what did I highlight it by? Oh, by the action, so the binding and the fusion. So when HIV, the cell comes into the body and it starts floating around, it starts to look for a cell. Oh, come back. It starts to look for a cell to latch onto, to use to help it replicate, right? Because viruses can't do that. They need a host cell. So they bind to a CD4 receptor, and we'll emphasize that in the next slide coming up. But it binds to a CD4 receptor. It's also called attachment, and it attaches itself, and then it starts to merge into the cell. But there are a few medications here. You can see there's CCR5's antagonists, post-attachment inhibitors. So I am not going to make you memorize all of the medications that are under all of these categories. It is extensive, and I just don't think that that makes any sense at all. But there are the broad categories, and there are a few medications that I did put in red, just so that you have an understanding of the different kinds of medications. So some medications would help to prevent it from binding. Once it fuses, it merges through the cell membrane and it starts to dump its genetic information. And there are fusion inhibitors. So if you've been pricked by a needle of a patient that has HIV, they may give you one of those medications as a prophylaxis, perhaps. And then we have the reverse transcriptase conversion and integration. So once inside the T helper cell, HIV converts its genetic material into HIV DNA, a process called reverse transcriptase. The new HIV DNA then enters the nucleus of the host cell, and it takes control of it so that it can replicate and copy itself. So here we have there's non-nucleoside reverse transcriptase inhibitors, NNRTIs, and then there's nucleoside reverse transcriptase inhibitors, NRTIs. So non-nucleoside or nucleoside. And those just are going to prevent the genetic information of the HIV cell from entering the human DNA or nucleus. Then we have, here we have, the next one is integration inside the CD4 cell nucleus. HIV releases integrase, an enzyme that HIV has. HIV uses integrase to insert or integrate its viral DNA into the DNA of the CD4 cell. So it integrates its DNA with the CD4 cell or our DNA. And then it kicks out something. So then another medication that they have discovered is called an integrase inhibitor. So it simply inhibits that enzyme that the HIV produces. So you can see, like, there's so many stops where they have medications to try and interfere with the different steps that the HIV virus will take. So replication, once integrated into the CD4 cell DNA, HIV begins to use the machinery of that cell to make long proteins, and it's just further down the chain of the assembly chain to try and be able to make its own, replicate itself in our bodies. Assembly, new HIV proteins, HIV RNA move to the surface of the cell. They kick out, and then a lot of times we hear the word, or maybe you haven't, but They talked about protease inhibitors during COVID because that was what that Paxlovid is. It's a protease inhibitor. So I don't know if you guys heard that ever. You guys probably never watched the news. I don't know if you don't do it. If you haven't started, don't start. But the protease inhibitors, so toward the end of the replication, the budding, newly formed, immature, non-infectious HIV pushes itself out of the host CD4 cell, which is, we'll talk about it in a second. I don't want to add too much. And the new HIV releases protease, an HIV enzyme. Protease acts to break up the long protein chains from immature viruses, and the smaller HIV protein combines to form a mature one that's infectious. So the protease inhibitor blocks that. Now, you may be saying, oh my gosh, do I have to remember every single step that she just talked about? In general, no, you don't need to know every little detail, but I would highly recommend that you try to visualize the process of an HIV virus entering a cell, doing some stuff, and kicking itself out. And that along the way, that there's many medications that stop that. And knowing that the medications, that there's the nucleoside and the non-nucleoside inhibitors and the protease inhibitors and the fusion, you'll go through, and I'll show you in the next slide how you can just make some flashcards so that you know the basics. This is not a deep dive because there's literally, I don't know how many, 20 different medications that they have for HIV treatment. And I think I have 4 or 5 that of one from each category. So you don't need to be able to spit out every single step, but I do want you to understand what the HIV virus does in a general way of how it gets into our cell. And then kicks back out to replicate and do the same thing to other cells in the body. So this is another slide that basically says the same thing that the previous slide does, just maybe in fewer words. The primary immune cell, this is a take-home point, the primary immune cell involved is a T cell, and it's the CD4 cell of a T cell. There's CD4 and CD8, and it's the CD4 cell of a T cell. So that's important for you to know. HIV is a transmissional retrovirus, and it hunts for these cells, and it fuses to the cell membrane, allowing the RNA from the HIV to be released into the CD4 cell. So this, what's basically written on this slide, you might star this slide as opposed to the previous one, just so you don't get overwhelmed with the previous slide. But I do recommend you look at it because it's really neat to see how those medications stop all those processes. But when it comes to understanding the overall process, this slide is simpler, less detail, and likely far more of where a question will come from off of this slide. Fair? You guys get that? Okay. So decreased CD4 T cell count occurs as the disease progresses and the risk of opportunistic infection increases. So as the CD4 count goes down, the patient is more susceptible to infections, more susceptible to cancers and oral manifestations in the mouth and candidias and pneumonias and all kinds of different things. And so highlight the term opportunistic infection, of which these are just some. So this list: tuberculosis, fungal infections, pneumonias, recurrent bacterial pneumonias, diarrhea, meningitis, and cancer such as Kaposi sarcoma or non-Hodgkin's lymphoma. Those are 2 big ones that tend to show up more often. As the amount of the virus in the plasma or the viral load, that's what they say when, like, they want to know what's the viral load. If you're carrying a virus and you're contagious, if you have a small viral load, you're likely not as contagious. If you have a heavy, and that's one of the things they actually have done in recent years, is they will reduce an individual's viral load, where they say that even through through sexual intercourse, that they won't even be transmissible. Like, they've put them down through such to such a small level that they're not even technically infectious. So kind of interesting, but they, if they get that viral load down, then it's almost not even detectable in their body. However, on the flip side, if their viral load is high, and their CD count is coming down and it's very low, then they will cross over the threshold from HIV to AIDS if they've dropped below 200. Sorry, I advanced the slide. Less than 200, if their CD4 count is less than 200, then they have converted to AIDS officially. Drug therapy, this is by no means a complete list. Super, super duper far from it. But these are the categories, and you can hearken this back by, you can look back at the pretty little diagram that I spent so much time talking about. And you can see how each one of these medications fit into that flow of how the cell gets taken over by the HIV virus. So we have, again, the categories here: the nucleoside reverse transcriptase inhibitor, non-nucleoside, protease inhibitor. These aren't in very good order, are they? That should be at the bottom. Entry fusion, that should be first. These aren't in good order at all. Integrase inhibitors, and then pharmacokinetic enhancers. So I just highlighted one from each of these main categories, which I think were kind of a little bit more, like, I don't know, I've heard those terms more, so I just preferenced those. But I figured it's like a sort of like a shot in the dark. I don't know the chances that if you see a patient with AIDS that they'll be taking these. There's so many, and they call it a cocktail. It's like the heart therapy. It's literally like a cocktail of drugs. Nobody takes one medication when they have HIV. They don't, nobody does just one. It's literally multiple. So I just put a few in there for you guys to have to recognize. But one thing I do want you to recognize, and this is actually on another slide, is notice the suffix that a lot of these contain: VIR, 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 VIR. So if a medication has VIR, it's most likely an antiviral. And that will help you a lot. And that's a good, you know, from a hygienist perspective, who we're not pharmacists, we're not doctors, we're not prescribing, really, I mean, other than a little. But so that kind of information is good. If it ends in VIR, it's likely an antiviral. And so you can feel at least knowledgeable in that fact. Post-exposure prophylactic HIV transmission is approximately 0.3% per exposure. So you get stuck with a needle. Chances are less than 0.5% that you would get, you would end up with HIV or from a patient who has it. But there is a prophylaxis regimen. Start within 72 hours of exposure to the virus. And the current guidelines are this Truvada, tenofovir, and this other one, plus raltegravir. And this is that you don't have to memorize the guidelines. You do not have to know the current medication, but just knowing that you would want to start it within 72 hours, and it's this is the percentage. Those facts are good to know. I'd like for you to know those. Any questions on this at all, on AIDS or HIV? You guys are so quiet. I am so sure all you're thinking about is your exam coming up. You are never this quiet. You always have questions. You're like, Jess, hurry up and get through it. Okay. Chronic hepatitis, hepatitis C. So this is the only slide, I believe, on hepatitis. It's pretty short. I don't expect you to need to know too much detail, other than most at risk for development of chronic hepatitis treatment. They do use a protease inhibitor for this as well. Hepatitis B is very treatable. That's good to know. And we're all usually vaccinated for that, right? Isn't that the one we all have to be vaccinated for? Oral nucleotide analogs. So there's treatment for that, though, if someone is not vaccinated for it. Characterized by inflammation of the liver, hepatitis, liver-itis, inflammation, pretty easy to remember that. characterized, and can cause either no or very few symptoms. However, it often leads to jaundice, anorexia, and malaise. Hepatitis is considered chronic when it's lasts more than 6 months. All of these, this little whole section here, I probably should have highlighted this. There's couple different questions that could be pulled from that theoretically. So drug therapy can last for years to indefinitely, especially perhaps somebody with hepatitis C. Drugs typically well tolerated, many drugs and antivirals, and in beer, I've already said. So take home point for that. Herbal supplements. I'm just going to go through this and then I'm going to let you guys go. So I'm not going to take a break because this will just take a few more minutes and then you guys can have the rest of the time to stress out and study. You'll be fine. You always are. You're a smart bunch of people. Herbal supplements. So for the objectives for this one, discuss why people choose herbal products over traditional medicine. Discuss the federal legislation governing herbal and dietary products. Discuss the safety of herbal and nutritional products and explain the adverse effects associated with their use and their impact in oral care. Explain the drug interactions associated with the products. Discuss the herbal supplements in oral health care. Okay, so there is an article in the Moodle page. It's like 10 densely packed pages. So on the off chance you don't read it, I highlighted the important stuff that I want you to know. But there is a couple big tables in there. So a lot of it, the table does make up some pretty big section. But herbal medicine, also called botanical medicine and phytomedicine, refers to the use of plants, seeds, berries, roots, leaves, barks, or flowers for medicinal purposes. And patients do not always report supplemental use, especially if it seems like a plant, like they're taking like a garlic tablet or ginger every day. They probably won't necessarily say it because, like, that just seems like food, right? Manufacturers cannot make claims of curing conditions. So you'll notice when you go to Whole Foods or when you go to any of these places and you look in the nutritional supplement and the herbal remedies that they don't make claims to lower blood pressure and things like that. Herbal products are regulated by the Dietary Supplement Health and Education Act, highlighted. So labeling is an interesting aspect of herbal or herbal supplements and things. Prevent the use of therapeutic claims on the label. So the regulatory bodies that are out there, they don't allow, like I said, therapeutic claims. You can't make a specific, this herb will do this, even though you may find in books and things like that. Like if you buy an herbal medicine book, you may find, what other what other countries or what other people or Ayurvedic medicine or different, Chinese medicine, all these, what they've used these for to treat. So it's kind of interesting. You can find out some really interesting information, but you won't see it in America on a label. Products cannot have labels such as for the treatment of hypertension. Labels can contain claims of the effects of a structure or function of the body. A natural product could say something like increases immunity. So it's being kind of a general term, like vitamins and minerals are good for your immune system, helps with immune health and things like that. So you'll notice the verbiage, it has to be a certain way. May not be necessarily scientific, but it cannot be false or misleading. So thought that was kind of a strange way of saying it. They just think of it in a different category. Like a lot of times there are no randomized control trials. They don't test these things the way that they test a protease inhibitor. And can anybody guess why?
Money.
Yes, money. You can't patent something like, you can patent like molecules, but you can't patent ginger. So no pharmacology or pharmaceutical giant would care about what ginger does because they can't patent it. They can't make money. I'm so cynical. It's terrible. Safety. So herbal supplements can still have pharmacological effects, side effects, and drug interactions, and like pretty good ones. So it's not anything to take too lightly, and treat herbal products as drugs. So it is really important, and it's a little overwhelming because just like pharmacy, there are gobs of different supplements and herbs and stuff that people could be taking, and it would be really, it's actually more challenging because they could be taking, prescribed medication and then supplements. You can look up the prescribed medications, but it might be harder to understand how their herbal supplements could possibly interact. So it's actually a little bit more challenging, really, in some ways. So like in the notes here on the side, herbal products can interact with more conventional drugs with serious consequences. For example, both ginkgo biloba and ginseng can increase the risk of bleeding when taken in conjunction with antiplatelet or anticoagulant agents. So like there are, and sometimes like surgeons and things like that, they will actually be quite privy to this information, and they will ask their patients, do you take St. John's wort? Do you take this? Do you take that? Because they know that there's documented interactions. So for quality, standardization is really important. The process that identifies one or more active ingredient of an herb, and all batches of the herbs produced by a single manufacturer contain the same amount of that active ingredient. So there are, if you are somebody who likes to buy things that, supplements or herbal supplements, it's important to find a reputable brand that standardizes what they are producing, and that you kind of find out the sourcing and if it's standardized. That's kind of just a good practice if you're interested in that. Good manufacturing practices standards were introduced by the FDA in 2003 to ensure that the dietary supplements are devoid of adulterants, contaminants, and impurities. And the United States Pharmacopoeia Convention conducts testing. They give like a seal of approval. So if you see this seal of approval, you know that their ingredients are supposed to be clean and free of, lead or some crazy thing. I don't know, something that could be in it. So some good stuff here. So oral side effects, St. John's wort can cause xerostomia. Obviously, I should have highlighted this slide. I obviously would want you guys to know this stuff. St. John's wort can cause xerostomia. Feverfew can cause oral ulcers, lip irritation, swelling, and gingival bleeding. Ginkgo biloba can cause increased bleeding in conjunction with other medications, like we already saw in the notes there. Echinacea can cause tongue numbness and taste change. But I just think it's funny because, like, my mom, she's kind of an herbal, both my parents are herbal people. And my mom was always like, if it tingles your tongue, that means it's fresh, when she was talking about echinacea, but it's supposed to be, it's an oral side effect. So anywho, kava or kava, oral and lingual dyskinesia. Why am I not? Okay, I got to look up dyskinesia. Someone look it up really quick. I forgot what it is. Google dyskinesia. Is it something? You can't move. It's like slow move. It doesn't. I know, that's what I was thinking. I'm thinking of Parkinson's disease. So maybe it causes tremors in the tongue or something. It might be like lack of, like a little bit like the soft palate or the tongue. There may be tremors in it or something. I'll have to look more into that. Okay, drug interactions, major concern, increased risk for toxicity and reduced therapeutic effect. So that would be your biggest concern, is that if somebody's taking an herbal medication, it reduces or increases the effect of a prescribed medication. So that would be the biggest concern. The most common negative result of drug interaction between traditional drugs and dentistry in herbal supplements is bleeding. Highlight that. I definitely want you to know that. Of all the things that we would be concerned about, if a patient comes into our chair and they're taking herbal medicines and other kind of medicines, many of them tend to increase bleeding. So that will definitely be a question that I'll ask on a quiz or an exam. You do not need to memorize all of that's on this chart. I just thought that it was kind of interesting because it shows some interaction between some herbs and then some prescribed medications. So cranberry is like pretty common and doesn't seem like that big of a deal. But if taken high doses of cranberry, taken in conjunction with opioids, can potentially increase the excretion rate of the opioid. And then golden seal, nettle root, valerian root, just different. Valerian has a sedative effect. And so taken in conjunction with benzodiazepines, barbiturates, CNA depressants, opioids can potentially lower blood pressure, which if your blood pressure is already low, and you know that could be not so great. And then there's just a huge list of different herb supplements here. And warfarin, heparin products, aspirin, these are all things that will thin the blood. They will increase bleeding. So all of these mixed with these is probably not a great thing for bleeding for the person. And then St. John's wort, did you guys know that in clinical studies, St. John's wort showed to be just as effective as like SSRIs and things like that? It's pretty interesting. It's quite an effective herbal. But I think there are side effects to it too. So, but anyways, in conjunction with these different enzymes, this, you definitely don't have to memorize that, but it just has, you can see how St. John's wort is quite potent and has quite an effect on the body. A lot of times when something is easily accessible, like you just go into Whole Foods and buy some and take it, you just think of it as like super safe and benign, but these things really do have a physiological effect on our bodies, because what are drugs but molecules taken from earth, right? And these plants are grown on earth. So it's like, it's all, it's all the same. It just depends on how much they slice it up and mess with it in the lab, right? So neat stuff. Herbal supplement used in oral health care. So here's sort of a summary of what you may find commonly in an office, in a practice. I'm not sure how to pronounce this. Aceman, hydrogel. Anyways, I know how to pronounce aloe vera. It's an extract of the aloe vera plant leaf that has immunomodulating properties. So it shortens healing. And I actually have seen, I didn't realize that it was this hydrogel specifically, but I have seen products that are this, and we had it in an office I worked at, and it was like a patch, and people could put it on their aphthous ulcers, and so it's supposed to soothe it and heal it, and make it feel better. Essential oil mouth rinse. What's that? You guys probably know what that is. Essential oils in a mouth rinse that's pretty popular. Well, good guess, but it's one that's, you can buy it, like you can buy this mouthwash. It's been around a long time. Yes, Listerine. It has essential oils in it, and that is like the therapeutic effect, or the essential oils in Listerine. And it really does, like, they have done clinical trials, and it really does actually kill bacteria. So, oh my gosh, come back here. So bacteriostatic effect on oral pathogens. So the essential oils like eucalyptus, and I can't remember, peppermint, and there's eucalyptus for sure. There's other ones though. Oil of cloves, eugenol. You guys, especially dental assistants, you've smelled the eugenol, right? And that has sort of a numbing effect. And IRM. IRM. Oh, IRM. Yeah, it's in IRM. Yeah. And then topical analgesic, so it helps with pain, reduce pain. Triclosan, I did not realize that was an herbal thing. I did not, because that's in like hand soap and toothpaste, and it causes the foamy. Significantly reduces plaque and gingivitis. So that, oh no, that's SLS that does the foamy. This just kills bacteria. So triclosan. And then xylitol, which you guys have probably had in other classes as well, cannot be metabolized by the S-mutan. So essentially we're starving them out. if we take on xylitol, like kind of a steady little bit throughout the day, you're pretty much starving out the S mutans because they can't eat it. And then it also inhibits the ability of microbes to adhere and grow to plaque. So it changes like that whole biofilm kind of slime layer, which is pretty great. Yes.
My office, we do arnica.
Oh, we did too in the perio practice. We had arnica. I have to look. What is arnica? It's a plant, but I have to look that up. That should be on this.
They have like ointment.
Yeah. Or that's. I should have added that to this list because I remember we had it as well. It is and it was supposed to kind of speed healing and help with inflammation. Yeah, I'll have to remind that. Thank you for reminding me. All right, you guys, that is it for today. Any questions? I'll be in my office. You can come and visit me, and good luck on your exam. You're welcome.